Hi everyone, we're going to go ahead and get started. Just to make sure everybody is in the right place, this is Achieving the Triple Aim with Data. I'm going to read the disclosure. You're going to hear this a lot today, but humor me for just a second while I read it. Good afternoon and welcome to Achieving the Triple Aim with Data, presented jointly by the Alliance for Home Health Quality and Innovation and the Visiting Nurse Associations of America. This session is being recorded. This continuing nurse education activity has been approved for 1 contact hour by the Maryland Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive your certificate of completion, you will need to attend this program in its entirety and complete the evaluation, available in the conference app. Certificates of completion are available at the registration desk. Our faculty has disclosed no financial conflict of interest. A copy of the full disclosure sheet is available on the table outside the room. I'd now like to introduce today's presenter. Barbara Katz is Vice President of the Clinical Program Development for VNA Community Healthcare. She is a graduate of Yale School of Nursing. Barbara has been a family nurse practitioner, a healthcare manager, and a healthcare consultant. She is responsible for agency marketing, business development, community health promotion, innovation initiatives, and value-based purchasing efforts. She has been active in the agency's clinical outcome improvement efforts, and she teaches a course entitled Driving Decisions with Data for Clinical Managers. She is currently working on a book on reducing healthcare fragmentation and connecting the dots of care for better patient care outcomes. So with that, I'll turn it over to Barbara.
Thank you very much. Whoops. Are we on here? Can everybody hear me? Is it okay if I stand down here? I'm a little vertically challenged, so it's really hard for people to see me. It just looks like the top of my head if I'm standing up there. Okay. So thank you all for coming. I'm very impressed that people came to this instead of to the marijuana or...
We went on honest before we came over.
Oh, okay. The inner secrets of VNSNY is great, value-based purchasing. So today we're going to talk about the nuts and bolts of data in an agency. And in case you're wondering, we have not completely achieved the triple aim yet at my agency, but I'll explain to you how we're on the road to doing so. So the disclosure statement you've already heard. The learning objectives today are to explain why data capability is needed to achieve triple aim goals, to describe the infrastructure and training needed for data capability, to identify key pitfalls embedding data into daily decisions, and how to create an action plan for assessing and improving data capability in your own agency. Does anybody need a refresher on what the triple aim is? Does everybody know the term? Great. Every single program I've been to lately, I ask for a show of hands of who understands what the triple aim is, and I usually get a couple. So home health care is much further down the road than a lot of other people on that score. So triple aim goals for healthcare. The triple aim is the value in value-based payment. There are 3 areas of focus, as I'm sure you know: population health and home health compare outcomes, Medicare outcomes, lower cost per episode, claims and internal metrics are the measures, and the better patient's experience, or HCAHPS. So before I go to this, let me tell you a little bit, put this in context for you. My agency is a medium-sized agency, I guess medium-sized at a national level. We're about a $30 million agency, 1,500 patients on service at any given time. We have a 100-year-old history. We're one of the old New England, original VNAs. And we started our data journey probably about 20 years ago, actually, when I first came to the agency. And the way that it started was they didn't call them chief information officers in those days. They were the IT guys. And our IT vice president was a statistician by training. And he taught the CEO and I how to pull queries out of the medical record using Access, an Access database. And he had one rule, which is a rule that goes through this whole presentation: don't try to do data unless you know how to ask the right questions. So this is about teaching people how to ask the right questions and how to embed data into daily decision making at the agency. So why data is necessary? It makes two things visible to clinical managers and to senior managers. One is patient populations, because you can't visualize a patient population. You can't walk around and see what your population looks like unless you drive around with all of your clinical staff, which obviously you're not going to do. So data makes your population visible. It also makes operations visible. And for many managers, operations are just a series of tasks. They're not really very visible. And data helps them understand what the structure and process of the work actually look like and what outcomes they actually achieve. It can help prove your organizational value, as we heard this morning in various and sundry presentations at the plenary session, how important data is. It helps you see progress or the lack thereof if you're trying to achieve your own improvement in outcomes and become a more valuable player in your value-based payment space or for other purposes. It's a key tool for achieving clinical, operational, and patient experience goals, because without good data, how do you know if you're making any progress? You need to be able to set goals, and you need to be able to achieve them to move ahead, and good data is absolutely essential to that effort. It helps make the case for change, especially when you have managers and staff who aren't entirely thrilled by the idea of the kinds of changes that we have to make to become more effective and more efficient. So showing people numbers achieves the last bullet. It cuts through the drama, because sometimes there's a lot of emotion around change, and there's a lot of we don't really need to do that, do we? And until you can actually show, hard numbers really can be very helpful in getting past some of the emotion and some of the opinions. And so I find that it's very helpful to use numbers when there's a change effort going forward. So our goals as an agency are to improve our home health compare star ratings and outcome scores, to increase our HCAP star ratings, to reduce the cost per episode, to improve regulatory compliance, because obviously that's a baseline thing that we all need to be able to do, to improve internal work process accuracy and timeliness, and to embed data-driven decision-making into the manager role. And the last piece is something that we've tried to do a lot of, because if your middle management and your upper middle management team is really using data to make decisions, people are a lot more aligned around the organizational goals and a lot more focused on where they need to go to help you improve your star ratings and your outcome ratings. So the key elements of a data program: first, goals and expectations, because people need to know what the purpose of the data is. Where are you going? How are you doing on your star ratings compared to benchmark agencies? What do you expect of people? Where do you expect them to approve? Where do you want to put your resources? Where is the agency focusing its efforts? And I find that middle managers particularly need some fairly concrete goals in order to be able to move ahead. And let me just say that one of the important things about using data to make decisions is to try to jolt people out of the task-oriented mentality that so many middle managers in home care and pretty much in the whole healthcare industry have. And so the clear expectations are essential as part of that work of achieving the goals. You also need data and analytics tools. And if you walked around the vendor marketplace today, that was pretty much all I saw, was either education, EMRs, or data and analytics tools. So I guess maybe that's a sign of that's where our industry is going. Data expertise You certainly need some of that. It doesn't need to be at the college professor statistician level, but you got to have somebody that has some kind of an idea of what's going on with the data and what it means. You need regular, readable, and understandable reports. I don't know how many of you have been subject to those sort of mind-numbing rows of numbers that roll out every month with the financials. I don't know about you, but sometimes I sit there and I go, okay, now which row are we on? What does that mean? And I'm sure that many people feel exactly the same way. Until the data is put into some sort of a graphic form for many people, it doesn't really mean much of anything. Training and coaching in data-driven decision-making. I don't see this being done a lot, but it's absolutely essential because even if, I find even people who have graduate degrees don't understand this stuff. So that's one of the reasons why I developed a course on the topic, because I found that, how do you think most managers feel about data? Let me ask you this. How do you think they feel when you ask them to start thinking with data? Anybody?
I think sometimes they want the data to validate their own thoughts about how the progress is going.
Yes, that's a good point. They do. What else do you think they think about it? Anxious. Yeah. A little anxious? I think a lot of people just about have a heart attack when they think about using data. I don't know. What do you think? Do you think there's anxiety among managers about using data and analytic tools? They do. Many of them see it as a time issue. Yeah. Exactly. Yes. Yes, there is in the beginning particularly when people are first starting it. I had occasion to do the data course for the Healthcare Association of New York State, and the audience was composed of two different groups of people. One was senior managers, and the other was mid-level managers. And I had people do a values clarification about how they felt about data. And the senior managers were like, wow, great, love it, I'm a data junkie. And the middle managers were like, oh my God, it's really scary. I don't know what it means. I don't have time to do it. So something to be aware of when you're working with your middle management group, that they don't necessarily love doing this. Okay. So training and coaching, and I think the last piece is you must have team structures to support improvement, because data by itself, what does it mean? Nothing. It's just numbers. You have to have methods for turning the data into actions and into practical, on-the-ground strategies for quality improvement. So in real life, data support tools. This is a list of what we actually use. If you walked around out there in the marketplace, there's a lot of comprehensive solutions that purport to give you everything you need from soup to nuts. We don't have that. We are much more do-it-yourselfers. I don't know how many of you are in the same boat, but we use NetSmart as our electronic medical record, and I find that there's actually a lot of meat within the built-in queries and reports within the medical record itself. I also find a lot of people don't even know what's there. A lot of people never look at that. And don't even know that there's a lot of information that could be extracted just by going to the right report and putting in the right parameters. So your own medical record may be a good source of information. I don't know if how much you've delved into it, but it's worth sitting there and just looking through at some point. We use Home Health Gold as our data scrubber, which has been a really invaluable tool for us because it allows us to extract data from the medical record and put it into understandable reports. It allows us to track our progress over time. It allows us, they have some standard reports where you can look at hot spots and adverse events, and so you're not always trying to think up all the right questions. It kind of pre-thinks for you. Does everybody here use Data Scrubber? Have a Data Scrubber? Pretty much? Yeah, great. When you talk to smaller agencies, some of them are like, Data Scrubber? Something you use with pots and pans? So it's a pretty valuable resource, I find. And we do try to get our managers to use it. I've found that getting people to run their own reports sometimes a little bit of a challenge, and they do need some help to figure that out. We use also Tableau. Does anybody here use that? Yeah. That was a new tool to us when we got a new CIO, and it was a real revelation how helpful it can be to integrate data from multiple sources. That was always a huge challenge for us, was being able to take data from different places and pull it together into some sort of a meaningful whole. And with Tableau, we're actually able to do that. That is not a do-it-yourself tool, at least it isn't for me. But for somebody with a data analysis background, it's proved to be super helpful, and I think it's pushed us ahead. And for those of you not familiar with it, I think it's sort of like Access on steroids. It's a much more powerful database, and it can pull data in ways that creates reports that are easy to, you can plug in parameters very easily. We use Excel spreadsheets for day-to-day drill down. And there's actually, I think, still a role for paper, pencil, and calculator. I don't know about you, I find it's helpful to get my hands dirty by actually going in and doing some manual calculations just to get a feel for the data. And so sometimes I'll actually just do that, just to see how it feels and how it looks to me, rather than just using standard reports. And then the last tool that we tell people to use is talking and listening about data and its implications. We really try to foster conversations about data and having people ask more questions and delve down a layer deeper. You know, the quality improvement tool asks why 5 times. So maybe the first answer isn't the right one, and then you want to go one more layer. So maybe you could say a little bit about what each of you uses for data tools. What kind of tools does your agency use? I hope you don't mind my making this interactive. I can't just stand here and talk. SHP, yeah, I hear that's a great one. Uh-huh. Uh-huh.
So we use Excel. What I would like to see, what I'd like to have is some more benchmarking when we're looking into that.
Oh, that's a great, yeah, that would be nice. Okay. Okay. What do other people use?
Just to comment on that, we use the financial modeling.
Benchmarking. Okay. Okay. Simeon's fine. Yeah, that's a great product. What else do people use? Yeah. Okay. 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 Right. Yep. So you're finding there's a lot of stuff within your own medical record. Yes. You had.
We have SHP as well as Home Health Gold, but then we use an overlay for NetSmart called Data DEYT.
Okay.
Instant access to census and things like that.
Oh, that's great. That's super. So you don't have to do a query. Okay. Anybody else have any favorite tools that you want to share with the group? No, nobody has the one magic answer, right? No such thing. So in real life, who does what? So this explains how we layer things out. Senior management sets the goals and applies the resources, offers the resources to people. We have a lot of support at the senior management level in terms of using data to make decisions, getting data, training on data. That's one of the parts of our corporate culture that I think has really evolved over the years. We do the higher level data analysis. We try to look at the big picture data in our senior management team and really understand what's behind the numbers, what's driving them. And senior management pushes everybody for higher performance. The expectation is that everybody will be working towards the corporate goals of achieving better star ratings and achieving better outcomes and better financial performance. Middle managers are expected to know the metrics for their own teams. And I'll show you a little bit about some of the team reporting that we do, but that is one of the expectations. They're supposed to be using data to analyze the causes of why things might be different in their team. So if one team, for example, has a higher readmit rate, then we would expect the middle manager to be looking into the reasons for that. So that's one of the expectations. And working with staff to improve results. So you'll see that we actually drill down all the way to the individual staff person level. And that's the job of the clinical manager to do that. We do have specialty clinical staff. We have our traditional QA department, which does the good old chart reviews, the 120-day reports, and looks at specific issues around compliance. We have a nurse, a complex care nurse, who, with myself and a couple of other people, we do the quality improvement team facilitation. And she looks at data related to value-based purchasing, readmissions, and she works with the ACOs and the bundling people and looks at that data. So we do have some specialty staff, but we don't have a real robust number of people that do it. Information systems manages the corporate data, the hardware, the software, programming such as it is. Our CIO is the one who introduced us to Tableau. He's a real data wizard. He worked at a casino before he came to us, so he knows a lot about predictive analytics, which is all about how casinos work. He told us the behind-the-scenes story of how they do it once and how they can tell who's gaming the system. It's quite interesting. And he's the CIO and IT are responsible to some extent for data integrity. And he, as he's always saying, GIGO, garbage in, garbage out. And that's a lesson that we have to learn. We do have a data analyst. This is a real luxury, I think, and one that's been really, really helpful. We hired a woman who was a former data analyst in medical group practice, primarily a financial analyst. Her expertise is in helping people ask the right questions and then being able to go to the right part of our data systems to find the answers. She's the one that creates the Tableau queries, and she also helps us to drill down if we want answers to specific questions. So just to give you a specific example, I'm trying to work with the clinical teams on the whole issue of, I don't even know what to call it, where you have the right nurse to be in the right place at the right time, scheduling and hiring. We used to think that we had lack of staff availability because we weren't hiring enough people. We found out that was not necessarily true, that the problem is hiring, staffing, and scheduling. And so scheduling, as you probably know if you've done any work on that, is an incredibly complicated thing that has to take into account geography, has to take into account who's part-time, how many people work on certain days, and how many people have a triage day off or absenteeism. So we've actually been doing a lot of work to get smarter about how to use data to help us analyze where we have help when we need it and where we don't. Has anybody else done that? Has anybody had experience with really drilling into scheduling? Have you? And what have you found?
What a lot of it boiled down to is that clinicians tend to remember the worst case possible as opposed to looking at the log averages over time.
Uh-huh.
And so we were able to compile data with the number of visits by day and then actually broke it down to hour, figure out exactly how many FTEs we need in each zip code.
Okay. That's a great example of using data to make decisions. We had an experience recently with, we have a disconnect between our intake department and our clinical team sometimes, because when the hospital sends over a batch of referrals, as you know, a bunch of them won't be discharged right away. So they have a pile on their desk they call the God only knows pile, which means God only knows when they're going to be discharged, if they're going to be discharged. So clinical sometimes thinks that this is an evil plot and that they're just holding up on those referrals until the worst possible time and then dumping them into scheduling. So we were actually able to look at data over time and get a sense of what the range of the discharges is by day of the week. And so there's actually a predictive model in there. Everybody thought that it was completely random and, who could tell? That's not true. There really are patterns. You just have to be willing to ask the right questions and delve down into it. And so we were able to dispel the notion that it was an evil plot and really show how it just has to do with variation based on the hospital census and that there are highs and lows in it. Okay, so let me just finish up with the analyst. She creates and circulates reports. It's her job to do all the standard reporting and circulate it to the management team. She actually meets with the managers every couple of weeks and reviews their data with them to make sure that they understand it. And she coaches them through understanding what they're looking at and asking additional questions to drill down deeper to, as we say, turn data into information. And the clinical VP, the director of nursing, and our QA director sit in on these coaching sessions so that we're able to really broaden people's view of data and what it means. And she helps us also with data integrity, because you know how sometimes you'll look at a number and you'll go, no, that just cannot possibly be right. That gut feeling that you get that there's a problem with it. So part of her job is to work with IT and with QA to ensure that the data integrity is good. So the clinical manager's role is to understand measures and targets, to know where their team stands against both the state, the national, and the internal benchmarks, to regularly review reports on team performance, and I'll show you what the dashboard is that we use, to analyze trends and gaps, to close the gaps and meet the targets. They're supposed to be using various strategies to take the data and turn it into actions that will improve outcomes. That's an area where I think we could do more work, because I think sometimes people look at the numbers and they go, well, what am I supposed to do with this? How do I go from point A to point B? And that's where we try to help people understand performance management strategies and quality improvement strategies that can help to close the performance gap. They do use data in performance management. That's relatively new for us. We never used to do that. In the last year, we've moved in that direction. And then lastly, they're supposed to use data to resolve operational problems. I do a lot of training, and I'm trying to get them to understand that that feeling of overwhelm that they have, where the tsunami's crashing over their heads every day, is actually the result of, some of it is the result of work processes that don't work right or performance problems, and that there are ways to use data to drill into that sort of tsunami of overwhelm and understand what's behind it. And one thing I tell them to do, you might try to get your crew to do this, I tell them to use data to analyze their own interruptions.
And so to take a pile of sticky notes, keep it right next to your phone and right on the top of your desk. And every time either somebody interrupts you or asks you to solve a problem, write down what it was. And do it for 2 weeks. At the end of the 2 weeks, stratify the data by type, see what the patterns are, sort it into piles, and then you'll have an idea of what's eating your time. And so when people do that, it helps them feel like they've got more control over their time. A lot of people don't want to be bothered because they say they don't have time to analyze what's eating their time. But seriously, right? Can you imagine your own managers being willing to do that? One of my managers did it, and she threw away the whole pile of stickies. And I said, why did you do that? And she said, I was just so proud of myself that I deal with all those interruptions. She didn't quite get the point. So these are the elements of our clinical dashboard. I didn't show you the real dashboard because it's a little bit of an eye boggler. It's a grid of numbers. And so the things that we look at all three parts of the triple aim as far as we're able to. So we look at average utilization by discipline, case weight, mix weight, number of admissions, average daily census, percent of Medicare admits, claims on hold for over 60 days. We've done a ton of work on using data to reduce claims on hold and to delve into the root causes of why there are claims on hold, which is a mighty interesting exercise if you are ever interested in doing it. One of the things we found when we did it was that part of it was a measurement problem, that in the billing department, people counted a claim on hold as soon as they got it. Not from their point of view, it was on hold until the money came back, which was a totally different definition than everybody else's. So just even talking about what we mean by the data can sometimes be helpful. We look at 30 and 60-day readmit rates, CHF and COPD readmit rates. We stratify readmit rates by reason. We really monitor not taking up referrals due to staffing. We had a real problem with it at one point, and people were, for a while, people were just like, yeah, well, we have NTUs. We don't have enough staff. And because in my real job, I'm marketing director, I said, well, wait a minute, that's money walking out the door. So we got finance to quantify the cost of each NTU and to report it out every month with the financials. And that was quite an eye-opener. And since we started doing that, the number has dropped. When you put the scheduling together with the NTUs, not taken up, where a referral was not accepted because we didn't have enough staffing. And it really is money walking right out the door. You got the referral, but you couldn't do it because you didn't have staff to take it. And that's how we backed into the problem of staffing, because we couldn't understand why we had NTUs when we were supposedly fully staffed. And we found out it was more of a scheduling problem than it was a staffing problem. But that wasn't obvious. Let's see what else. We look at star ratings by team. Those are not risk adjusted. Obviously, that's not what we get from Medicare. That's our own data. The gap between performance and goals, we're constantly looking to try to close the gap. We do home health compare clinical outcomes by team. We benchmark, do a lot of internal benchmarking. And obviously, we do outcomes compared to state and national benchmarks and the organizational star rating, which is the rolled up score. Yeah.
Not clinician productivity?
We do look at productivity, yes, we do. Although, interestingly enough, could open a real can of worms to say this, it's sort of like warring incentives. So if you put too much emphasis on productivity and you don't balance it with if it's not a balanced view, it can create the wrong idea. And we have found sometimes our traditional measures were all about productivity. The clinicians were so obsessed with productivity that it really sort of took them away from thinking about quality. But we do measure it, yes. Sorry about that, I missed that one. Anything else other people measure that you think is really valuable?
Utilization of services. We have on our clinician dashboard, routine dashboarding, clinician
Okay. Yeah, we do that too. Okay. Anything else that I missed that you think we should be measuring? Okay. So structures for data-driven decisions. We have a variety of them. Some of them are more effective than others. We have the good old-fashioned QA data reviews and the corrective actions. The QA reviews used to drive me crazy because the sample sizes are so small. They're really not statistically significant at all. I like it when they point you in a direction and then you delve deeper and get a bigger sample and really try to see what's going on there. But we did recently do one that I thought was very instructive, where we did, our QA department did an analysis of chart audits that delved into some of the reasons for readmissions. Like delve deeper than the obvious, which was just falls, UTIs, and all that, and really found that one of the underlying causes is clinicians not reacting or responding to changes in condition. And we're still trying to understand exactly why that is. Do people see what they expect to see? Are they in too much of a hurry? Is it that our charting is not set up in a flow chart kind of way where you can see vital signs over time? We don't know yet. But that's a project that we're popping up to the more senior management level to look at. There are I mentioned that we have analyst clinical manager reviews once a month. The managers sit with the analyst and go over their own data. We do the dashboard reviews. When the nursing teams get together, they look at the dashboard with the director of nursing and talk about what's going on there and what they're going to do about it. We have complex case conferences with staff. Those are conferences where the staff call it. If they feel like they're overmatched by a case, they can request an interdisciplinary team conference, and we try to use data there. We have an interdisciplinary management team, which is composed of all the clinical managers and a couple of us who are facilitators. And that's where we're trying to look at the big picture of our star ratings and go backwards into the causes of readmissions and areas where we're scoring lower on our scores. And right now we're starting to look at that whole issue of responding to changes in condition and also interdisciplinary conferencing and how we could do a better job of connecting the dots for patients. Quality improvement teams. Unfortunately, we have a lot of them. I wish there was a shorter way or an easier way to do it, but we have found that if you want to make a dent in a big problem, claims on hold being one of them, it really takes a full quality improvement team with a facilitator and an improvement plan and robust data and getting everybody in the room to solve it. So if anybody has a quicker way, I'd love to hear it because we haven't really found it. We found that you have to delve deep to get into the guts of what's going on with some of these huge, very, very difficult problems. And manager coaching sessions with staff. So managers are now using the data that we pull on individual employees. They're supposed to be doing clinical coaching with their staff. And if they see certain nurses, for example, have a much higher readmission rate or a much lower telemonitor use rate, then they're supposed to be doing, looking at why, what's going on there. And some of the answers are very interesting when you hear why people are not doing these things. What do you think some of the reasons might be why people don't use telemonitors or might have a higher readmission rate? Maybe yours are different than ours.
If it's the clinician-driven decision, it might be that they have to set it up.
Yeah.
Yeah, so, you look at things like drop shipment, patient instructions that are friendly that they know how to do.
Exactly.
Yes, sometimes looking at data will show you there's a systems problem. And that's a biggie, that we as management have created a barrier. And so that sometimes is, what other things do you hear? When do you think you hear?
I think it's a culture change and just getting them to think of it. Like they know they're supposed to reduce rehospitalizations, but oh yeah, I got this home monitor.
Yeah, sometimes it is, and they're overwhelmed too. You know, it's being case manager is no easy job. I think it's quite overwhelming. What else do you think?
If they're seeing the patient, they have it planned out Monday and Friday, and they get an alert midweek, they actually have to do something, and they would rather push it. You know, it's just not something they plan for in their workload, and it's
Yeah, it sure is. Especially if you're on one of those rote visit schedules where it's just like, okay, 3 times a week, whether you need it or not. Yeah.
I think it's too how you plan the roles of the home nurse and the telehealth nurse. If you're both functioning at the top of your license, that makes a huge difference in the lot.
I think you're exactly right. Well, there are some other reasons too, but I'll wait till I get to the part about perceptions. There's some interesting perceptions.
Going along with what he said, one of the diagrams which are readditions look back to see if there's a change in conditions, and if you require to do diagram to medical record, then see the on-call log, and many of the times statistically it showed the on-call nurse, whether it was at night or in the afternoon, I picked up the phone and somebody said I'm coughing or I have a fever or whatever it is, and they said, well, you better call your doctor, and then it was gone.
There you go. Yep, exactly. Whole variety of things. But when you start to look at the data, you begin to see the patterns, both at the team level, because each team has its own culture, and each branch has its own culture, and then down to the individual nurse level. So the training that we do, the training can either be a full day or a half day. And first step is to address fears about data and measurement. And what I always tell people at the beginning is, I'm probably the worst person in the world to do this because I almost flunked high school algebra. I picked my nursing program because there was no math, and I needed a tutor for statistics in graduate school. And then everybody relaxes, and I say, if I can do it, you can do it. We explain the use of data in a value-based purchasing context. I find that a lot of managers really don't understand the triple aim, value-based payment. The whole concept is alien to them. And it takes a while for them to wrap their head around it because it's a complete paradigm shift. Just like that gentleman said about you have a visit schedule and you go out and just visit. That's not what you do in value-based payment. You're working towards a goal, not towards a series of tasks. So this is hard for people. We talk about the clinical manager and the senior manager role. We use a 4-step process, which I'll show you in a minute. And I just teach 4 tools: trending, benchmarking, stratification, and talking and listening. Because data's a team sport. It's not an individual sport. Otherwise, if you're just doing it yourself, you might come to the wrong conclusion. And then we talk about techniques for closing performance gaps. These are the 4 steps in the process: ask key questions, assemble data, analyze to turn the data into information, and act on your information. And we call it the 4 A's. So how we've used data for improvement. I'd love to tell you that we're a 5-star agency on both HCAHPS and on Home Health Compare, but we're not. We're 3 stars on Home Health Compare. We're edging our way up, but as our CEO says, this is just painfully slow, and it really is. But when you think about all the variables, it's understandable. We're 4 stars on HCAHPS, and we're trying to move to 5. We've done things like sending out orders, sending out the 485s. We were at about 62% compliance with our state law, which is a 21-day turnaround time. It was horrendous. And we were mailing things. We had paper flying in every direction, doctors calling. It was fairly chaotic. And we did an improvement team with our medical secretaries and our medical records department. And we introduced some smart search technologies and virtual faxing, and we were able to reduce the order cycle time by 50%. So we really don't have a problem with it anymore. And as a side effect, we have medical secretaries who are probably among the smartest data people in the organization because they really learned how to think with data. We reduced NTUs. I think I mentioned that by looking at the guts of how our scheduling system works. We use case manager scorecards for performance management, and we were able to really reduce the dollars in our claims on hold by doing, looking at what was the cause, what were the underlying causes of the claims on hold, and then trying to knock through each of the causes with a quality improvement team. So this is a comment from one of the clinical managers. I asked one of them how they felt about managing with data, and she said, the reports we get on high-risk patients are hugely helpful. I have 250 patients on my team. How could I monitor them without data? These reports help me work with the nurses and the schedulers to manage care as a team. So she makes sure when she gets her high-risk list, which we do, we have a real-time high-risk patient list that comes out of Tableau. She makes sure the scheduler doesn't push those visits. If the nurse is out, or if the nurse is thinking, boy, I could use a little rest from these high-risk patients, she's looking at the scheduling to make sure that those people are getting the level of intensity of care that they need. And she really likes the case manager dashboard because then she can compare OASIS scores between nurses and use the scores to coach and educate. And the dashboards go into the employee files, and she uses them for performance appraisals. We had some tough nuts to crack in terms of people's old-time case managers who really thought they knew better than the best practices. And this has helped crack through that. And it's helped crack through some of the drama of, well, your opinion, my opinion's as good as your opinion. And so I'll give you an example. The whole issue of a lot of case managers being resistant to using best practices for CHF COPD patients who have a secondary diagnosis. They really never grasp the idea that it's like diabetes. CHF doesn't go away. You always have it. And we were able to use data to show them that people with a secondary diagnosis go back to the hospital sometimes just as frequently as those who have it as a primary diagnosis. So that was sort of an urban legend that got blown up by looking at data. And this is what the scorecard looks like for the individual nurse. It shows the score and the number of episodes, and then it shows how she's doing, he or she is doing against all other case managers. This one's pretty good. Some of them are pretty scary and really involve some serious clinical coaching and performance management. How many people use this? How many people do individual clinician scorecards? Most people. Okay, good. This is showing you some, well, mostly improvement. I just noticed the hospitalization didn't improve. It's going in the opposite direction, so I got to take a look at that. But this was a branch. We had acquired another company about 5 years ago, and let's just say their OASIS scoring needed a little improvement. And so this was an old-fashioned look at the score, drill down into it with very intensive education, both at the branch level and at the individual clinician level. This is our QA department did this, and we did a lot to improve the scores. And they were dragging us down in terms of our overall OASIS scores. But once we used the data and we were able to drill into it and use some improvement, OASIS training and improvement coaching, you were able to really see a difference in the outcomes. The pitfalls of using data. Lack of clarity about goals and expectations makes it very difficult to use data effectively. Lacking financial resources for tools and person power. Now, I know a lot of people, almost everybody here said they had a data scrubber. In other meetings I go to, say at my state level, a lot don't. They just, not everybody can afford those kind of tools, especially smaller agencies. Sometimes the culture is hostile to data-driven decisions. People really want to manage based on opinion or experience or, I don't know, what they learned in school maybe. but you don't always see a willingness to use data. And somebody said people see what they want to see or they're scared of what they're going to see. Didn't you say that? Somebody said something like that. No time to think straight. That's the overwhelm issue that was mentioned. Don't confuse me with the facts. I'm sure you don't have any staff like this, right? But so if you had to say whether home care nurses are like cats and dogs, which would you say they are? Cats, of course. I always say home care nurses are like feral cats. You can't train them, but you can move their food bowl. And data is their food bowl. It helps. But there are a lot of belief systems that really need to be exploded. And one of them, unfortunately, I hate to say it, is ageism, is the idea, for example, that that seniors can't use technology. Or that, why would I really want to do strengthening, call in PT to do strengthening with a frail patient when they're just going to go downhill and die anyway? That's the way it works. Or old people just fall. Stuff that you just go, what? But truly, there are such belief systems out there, and you have to try to substitute them, facts for those things. And then poor data quality. Certainly what people put in this system is going to have a big impact on what you can pull out. And when I teach the course, I always talk about data integrity as a big issue. And that's why you want to be talking to other people about what's in the data. So, for example, do you count a discharge as a real discharge, or is it a discharge plus payer change? Some people count payer change as a discharge from one payer to another. That's a big difference in terms of how that impacts a lot of different things. So you have to be sort of always asking questions. So everybody can do this. I think in this crowd, this is not a problem. It sounds like you're all on the sophisticated side. But even if you don't have a data scrubber, an analyst, structures for analyzing data, formal training, and an organizational dashboard, you do have Medicare reports. You do have your EMR. It most certainly has queries and reports. You have a QA department. Somebody has an inquiring mind in your organization and can ask questions about data. You have paper, pencil, and calculator. There's always somebody who knows Excel, and they're probably in finance, right? Before we had an analyst, it was finance that helped out with the data analysis. They were the people that really got how to drill down into the data. And then online resources for data and QI tools. There's tons of them. You can ask the internet anything you want, and it will tell you. So, if you were to do a quick organizational assessment and rate yourself on a score of 1 to 10, why don't you take a minute and just do this? So look at each of these things and see how you rate. You monitor home health compare and age caps. You identify target goals. You communicate goals to managers and staff. Your managers have data expertise, senior managers. You have the resources, hardware, software, analytics, and time. You educate managers on data-driven decisions. You send around dashboards. You have all the team structures to support data. You have support staff to help. And you take a no-blame approach to data analysis. So how many people got 100? Anybody? How did you score yourselves? I'd give us about a 75 or 80. Nobody got 100? If VNSNY was here, they would have gotten 100, I bet. And then lastly, an action plan for data management. So list one pressing reason for your organization to use data more effectively. What might that be? Why would you want to be better at using data? Improving outcomes. What else? I'm sorry? Be prepared for whatever. Yeah, that's a good answer. What else? Anything else? Yes. Better quality decision making. Yes, it helps explain change. Resource allocation, that's a big one. Lowering costs, huge tool in terms of lowering costs. Absolutely. Excellent marketing tool. So 2 data management gaps that you would like to close. Yeah, I'm almost done.
I would say, the structures are there, but, actually being able to adhere to the structure that's in place.
Yep.
Other competing priorities.
Absolutely.
Whether it's the interdisciplinary case conferences that we set up, and we have a structure for this every Monday afternoon, and we use a high risk for hospitalization reports to feed those patients into that. There's still volume, every other imaginable interruption.
Absolutely. That's huge. I think getting pulled off the mark is just a huge issue. What else? Any other gaps that you'd like to see you'd like to close in your organization? Okay. Guess everybody's doing great. And think about some steps that you would like to use to close the gaps. And then if you want to download the presentation, there are a few resources. There's a ton of information out there about using data, although not so much in home health care. There's about using data, but not how to get to using it. That, when I went to prepare this, I thought there'd be dozens of articles, and there really aren't. The mechanics of it aren't talked about all that much. So I'd like to thank you for your attention and appreciate your coming.